Hello, my name is Margo Mountjoy, and I'm a clinician scientist from Canada, Sport and Exercise Medicine. It is my pleasure to be with you today, virtually, for your Sport Medicine Conference. I'm only sorry that I could not be there in person to enjoy learning from you, spending time with you, and seeing some of your beautiful country. However, I am very delighted and honored and thank the organizing committee for the invitation to speak to you today. I have no conflicts of interest to declare, although I am a member of several international federations and sport organizations as a volunteer, including the IOC, WADA, ASWAF, FINA, World Rugby, and FIFA. So today I'm going to spend some time talking about female athlete health. And I think it's important that all of us are skilled in looking after female athletes, because when we look at the participation of female athletes at the Olympic Games, you can see that we're almost at equal parity with our male counterparts. So if we start on the far left, if we look at the Winter Games, the very first games that women were involved in Chamonix in 24, there was only 4% female participation. The most recent Winter Olympic Games in Pyeongchang had 41% female participation, so significant improvement since the original women's participation in Chamonix. If we look at the Summer Olympic Games, the first Paris Olympic Games in 1900 had 2% female participation, and Tokyo 2020 will have about 49% participation, so very close to equal distribution of women and men in Tokyo 2020. If we look at the Youth Olympic Games, you can see that Buenos Aires, the most recent one, was at 49.7, and not on this diagram is Lausanne 2020, the Winter Youth Olympic Games, where there was equal 50% female and male representation. So as a sport medicine clinician, we really do need to have the skills of how to look after female athletes. So thank you for your interest in listening today on how we can better improve the health and well-being of our female athletes that are under our care. And it is important to note that it's not just something we should do because of participation. We should do this because it is something that's encouraged from the top leadership throughout sport. That the IOC itself encourages and supports the promotion of women in sport at all levels and in all structures, with a view to implementing the principle of equity between male and female participation. So with that guiding principle, we should be encouraging women not only in sport to become and remain active as athletes, but also in sport medicine, sports science, and sport leadership. Let's focus our attention today, though, however, on how we can best look after the female athlete. And I think this picture tells it all. Women and men can have partnerships in sport that are very strong, but look at these two individuals that are on the same team. This woman here is not just a little man. The presentations and complications and challenges that she may face will be different than her male counterpart. Female athletes are not small male athletes. So we cannot take the same approach and the same principles and knowledge and just apply it to smaller people, women. So today I'm going to break my talk down into different topics. We'll start off by discussing the types of injuries that women are more likely to occur, the mental health of female athletes, how the nutritional requirements are different. We'll talk about contraceptive and menstrual health challenges that women face, stress incontinence, abuse and harassment, and close off with a talk about exercise during pregnancy and return to sport post-pregnancy. Let's start off with discussing injuries that female athletes face more frequently than male athletes. So in particular, female athletes have a greater prevalence for concussion, ACLs, stress fracture, ankle sprains, and patellofemoral joint dysfunction. Because of time constraints today, I'll focus on the first three. So the ACL injury, if we look at some data from Barth, you can see in the alpine ski that females had 1.65 greater risk of occurring an ACL injury than male counterparts in this study. Most of these were non-contact in nature, as we know from the mechanism of ACL, and were often related to poor biomechanics, either poor pelvic or core strength, or quad to hamstring imbalance with hip internal rotation, which I think is nicely demonstrated in this female runner here. See the hip internal rotation and the valgus deformity of her knees that she has. Most often, this is a surgical repair. I will not go into details of the types of surgical repairs, and there is a risk of long-term osteoarthritis in any athlete with an ACL that's been disrupted. So it behooves all of us to prevent the long-term health sequelae by preventing the actual injury, because not only are there short-term performance challenges, there's also long-term health consequences. And what we found in this study by Judge is that the FIFA 11 plus exercises, which have been proven to be effective prevention exercises, are actually not well adapted or implemented within the sport context, despite the knowledge that it works. So in your sports that you work with female athletes, are you ensuring that they're doing the prevention exercises for ACL injury? And if not, let's start tomorrow. Let's talk a bit more about stress fractures now. By definition, a stress fracture is a microfracture in the cortex, or that cortical bone, that's the result of abnormal remodeling in the setting of repetitive stress impact. And I'm sure you see this in your practice. I certainly see it in mine. I look after long-distance runners and triathletes who have regular stress fractures. Now, my challenge is, of course, how can I prevent these stress fractures because of their impact not only on the well-being, but on the time away from sport with injury. So there's a study by Ackerman et al., and I've shown the diagram here on the left that shows that those athletes that were amenorrheic had close to 50% chance risk of having stress fractures and non-stress fractures. And 25% was what the eumenorrheic or regular menstruating women were, compared that to the non-athletes, which were 12%. So we know that there's an interaction between the risk of stress fracture, being an athlete, but more so being an athlete with abnormal menstruation, which is thought to be through low energy availability. So we know that the risk connected with having amenorrhea leads to low bone mineral density as well as an increased risk of stress fracture. So there's multiple factors involved in stress fractures in female athletes, including metabolism, the biomechanics of how that athlete has the stresses through the bone, the load that the athlete has in that bone, and how thick the underlying bone is to begin with, which is very genetically driven, of course. So to treat these stress fractures, address the biomechanics and change the cause. You've got to give them time to heal. Having them heal and then starting them back to sport doing the same program they did before is going to result in another stress fracture. So while you diagnose a stress fracture, give it time to heal. That time should be spent trying to correct the underlying cause. So you as a clinician must spend the time being a detective thinking, why did this stress fracture cause? Was it a training error with load? Was it a biomechanical error that I can correct through shoe adaptation? Was it a strength imbalance that was causing this? Or was it abnormal metabolism through low energy availability and nutrient deficiency? So our job isn't done just by diagnosing and giving it time to rest. Our job is not done until we find the cause and prevent it from recurring. We know stress fractures, the greatest risk factor is a previous stress fracture. So let's stop the cycle by finding out the cause and preventing it from reoccurring. Concussions. Concussions are 3 times more likely to occur in females than in males, and we know that female athletes have a prolonged concussion risk relative to the male. They will more likely have problems if they have underlying mental health problems, if they're younger in age, and as I mentioned, if they're a female athlete. Recovery is slower in female athletes as well. Treatment. Recent changes, some great work done by Schneider et al. From Calgary, showing that 24 to 48 hours of rest followed then, even if symptomatic, by some sub-symptom threshold, sub-maximal exercise under controlled settings has a faster return to sport and recovery than an athlete who's left just to rest until completely asymptomatic, in conjunction with some neurocognitive and cervical spine treatment. Let's move on now to the female athlete with mental health challenges. Women are more likely to have problems with eating disorders and disordered eating, as well as depression and anxiety. So eating disorders, I've put some prevalence data up here for you to see that it is more common in the aesthetic sports and endurance sports than in team sports. And the etiology is also multifactorial, being biological, psychological, sociocultural, and some sport-specific risks. Signs and symptoms, you may see only behavioral changes, but often in the anorexic one, you will see physical changes of being quite low body weight. But remember, bulimic athletes or a mixed presentation will not have the significant weight loss, but there will be psychological sequelae that can present. Depression. Females are twice as likely to report depression symptoms than male athletes are. And it's thought to be equal to the general population. However, there's decreased reporting within sport due to the stigma of mental health problems within sport. So we think although the prevalence data is equal in sport to outside of sport, we think it's probably higher because of the stigma attached to reporting. Risk factors for depression include genetic factors, environment, injury, failure at competitive failure, and retirement. Anxiety disorders. Female athletes are also more likely to report anxiety than our male counterparts, with a prevalence of about 15%, and we know it's worse when the athlete is injured. And they may present their anxiety in different ways, be it social anxiety, obsessive-compulsive disorder, panic attacks, or phobias. The treatment, very interesting, and specifically in women, that cognitive behavioral therapy has been very effective in treating anxiety in female athletes. But there's also medications that can be used in athletes, and I encourage you to use them appropriately because the side effect profiles of many of the antidepressants and anti-anxiety medication can inhibit sport activity. I'm going to introduce you today the Sport Mental Health Assessment Tool that was published in 2020 by Godebej et al. And I was part of this writing team. It was a privilege to be part of this team. And this mental health assessment tool is designed like the concussion assessment tool. It's meant for you to use to screen athletes to identify those who have mental health problems. It's very easy to use, the first part, and I show you the algorithm here. The first part is a screening tool which identifies those athletes with psychological strain. If they not have any, or the score is less than 17, the athlete is finished. If the score is higher and it shows they're having some psychological challenges, then the athlete is asked to complete 6 different tools for depression, anxiety, sleep disorders, eating disorders, drug, and alcohol problems. Then those are all scored with a trigger and threshold. Above that, they receive treatment. Below that, they get some minor cognitive behavioral therapy and rescreening. So it walks you through the screening, diagnosis, treatment, and rescreening. So it's quite a helpful tool. I think you'll enjoy it. Please use it. Let's move on to nutrition requirements for the female athlete. So we'll focus initially on iron deficiency and then mention REDS and finally bone health. So iron deficiency is a fairly common problem in female athletes, and they're much greater risk than the male, with the prevalence being 5 to 35% in female, whereas only 5 to 11% in male athletes. In triathlon, there's a study that shows that the triathlon prevalence was 20% in this cohort of Canadian athletes. And the consequences of the low iron can lead to anemia, poor performance, and of course, blunted response to altitude training with a low acquired hemoglobin mass that's expected and desired through altitude training. And of course, the female athletes have the added challenge of loss of blood through menstrual loss, assuming they're having regular menstrual periods. REDS, or relative energy deficiency in sport, is underpinned by low energy availability caused either by restricted intake of energy or excessive expenses of energy on the other side. And using this diagram, you can see on the far left, this is an athlete who's intentionally restricting their energy intake through reduction of their diet, and that can lead to REDS. On the opposite end of the diagram, there's the athlete who eats well, but has excessive energy expenses through endurance training. Now, this athlete has no disordered eating or eating disorders. They just are spending a lot of energy through exercise, so it's unintentional low energy availability. And of course, our happy athlete in the middle has adequate energy intake to balance their energy output, and they're in a healthy, balanced state, so they will have no health consequences. So here's the formula, where energy availability is the sum of the energy intake through diet minus the energy expenses through exercise, and that's divided by the fat-free mass in kilograms of fat-free mass per day. So a normal individual will have 45 kilocalories per kilogram of fat-free mass per day, and when that decreases to the level of about 30, that's when the athletes will get into troubles with body system shutdown. So to define the term, REDS is a syndrome that it refers to impaired physiological functioning that includes, but it's not limited to, all of these different things that are mentioned: metabolism, menstrual function, bone, immunity, etc. You can read them, and I find it maybe a little easier to see it in this diagram rather than reading it, that energy deficiency is the core cause that can cause all of these different body systems to have negative effects. Now, not every athlete will have all the body system affected, and different athletes will have different ones affected. I draw your attention to the pink one on the left marked as psychological, because this is the only body system where it can actually cause the energy deficiency itself through disordered eating and eating disorders. So not only will the energy availability cause mental health challenges can cause the energy deficiency. So that's the one unique one of all of these health impacts of low energy availability. There are also performance impacts from REDS, and they're listed here. Our science is not quite as robust as it is with the health impacts, but nonetheless they still exist, and there is some burgeoning evidence to show these. And finally, there's a REDS concussion assessment tool, much like the IOC SMAT or Sport Mental Health tool and the concussion tool. This tool is for your use in your clinical practice with athletes, and I use this on a daily basis at my clinic with my athletes. It's very easy to use. And next we'll speak about bone health for athletes, and you can see with the diagram on the left that the most common influencer in bone health is our genetics, which we can't influence our athletes' genetics, but we can influence their nutrition, hormones, and mechanical forces. So we can have an influence through diet, making sure there's adequate vitamin D and calcium to ensure healthy substrate to grow healthy bones, especially in our teenage athletes in that window where you have the most bone accrual. And you can see that in this diagram nicely. The pink is the female athlete, and you can see the age of which there's the most bone is accrued through the ages of 12 to 17 in the female, and the male a little bit older, 13 to 19. So critical time period to make sure our athletes have the appropriate nutrition for healthy bones. I'm just going to pause to mention briefly that body composition management, by bringing an athlete's body composition down to a peak competitive physique, is really important to be done only at the elite level in the most controlled situation with physiologist, physician, and dietitian, and done slowly and with intent to minimize health impacts by maximizing performance. And this is a lovely case study of how this can be done very safely. You can see the stars are when this athlete competed, and that's when she has the lowest body composition. And then for training, she periodizes her body composition to a slightly higher fat content so that she can decrease injury risk and health complications. And then it's brought down slowly again for the next competition. So a very nice diagram on how well, it's not so easy, but how one can safely periodize body composition without complication of REDS in the right controlled setting with the supports of the experts. So nutrition for performance, I will mention briefly about supplements. You can see at the top of the pyramid, very small percent of performance is really enhanced by supplements. The rest of sport performance is really about having the right amount of energy, the right amount of macro and micronutrients, timing it properly, and have healthy food and eating habits. If that happens, you don't need any nutrient supplements. Let's move on to contraception and health problems, of menstrual health problems in female athletes. So there's been wonderful work recently published in 2020 in Sports Medicine, the first one by McNulty et al., that showed that during the menstrual cycle, there really isn't much difference in sport performance throughout the menstrual cycle. Trivial reduction of performance in the early follicular phase, but not significant. And there was no difference in all of these other factors, and these were all measured throughout different phases of the menstrual cycle to see if there were any performance benefits at any specific time of the cycle, and the answer is no, not really. There was a little evidence that there was running economy was worse in mid-luteal phase in this one study by Goldsmith, but fairly mild changes. And really the message to physicians, to athletes, should be that any training modifications throughout the menstrual cycle should be individualized to that woman's experience. If you have a woman who's a heavy bleeder or has a lot of symptoms of premenstrual syndrome or pain during their menstrual period, those athletes should receive attention and have their exercise modified. But for the most part, the timing of the menstrual cycle should have no effect whatsoever on an athlete's ability to participate in either training or competition. But what about the birth control pill? Does it affect performance, athlete performance? And there's a lovely study, again, 2020 by Sports Med of Elliott Sale, which is actually one of the McNulty group, and there is no performance enhancement with the oral contraceptive pill. And I think this is important for all athletes to recognize that they will not get a performance enhancement. There was actually a small performance positive effect from not taking the pill than taking the pill, but it was so trivial that it really didn't seem to make much difference in terms of strong enough to make a recommendation. And it was fairly consistent across the entire oral contraceptive pill cycle. So let's talk about an abnormal menstrual cycle. There's oligo, or not too frequent, poly, which means too many. If we talk about the amount of bleeding, we have menorrhagia, or too much bleeding. If it's irregular, it's metrorrhagia. And if it's irregular and heavy, it's a bad day, that's menometrorrhagia. So just some terminology to keep us on our toes and remind us of medical school. So what happens, what do we see in athletes? Well, we can see the amenorrhea, oligomenorrhea, and don't forget about pregnancy. It's not always REDS. It can be polycystic ovary or pregnancy, and these are things one must rule out before you diagnose REDS. I also see menorrhagia that needs to be managed in athletes as it is in other women that are non-athletes. as well as dysmenorrhea or painful periods that can be easily medically managed as well. I think most importantly, if I can leave you with any thoughts on menstrual cycle today, it's time we stopped the stigma of not talking about menstrual periods. Coaches and athletes do not understand the menstrual cycle and its impact or lack of impact on sport performance. And I think we could play a part in ensuring the culturally and sensitive destigmatization of talking about the menstrual period. We spend a lot of time and effort talking about diet and joint function and muscle function, MVO2 max. We monitor everything in the athlete, mood states, but we don't monitor their periods. And it should be a performance parameter that we do measure in light of the effect on preventing all of the troubles that occur with REDS. It's time for us to break the taboo in sport culturally, sensitively, with our female athletes and our coaches. Let's move on now to stress incontinence, and something we also don't talk much about. Causes mainly of pelvic floor dysfunction, as in non-athletes, can be pregnancy, birth, older age, obesity, or gynecological surgery. Sport-related might be more strenuous work or exercise, but other health causes, constipation, coughing, or conditions that increase abdominal pressure. Let's look at some prevalence data. Wow, 45% in women, 17% in male in this cohort of athletes. This is not general population, this is athletes. Females, 5 times more likely than male athletes to develop, and 31% reported it according to the reporting structure as being moderately severe, and a quarter of them had troubles while training, specifically around jumping and running. Professional athletes were more likely to complain of stress incontinence or urinary incontinence than the recreational athletes, and this is a volleyball population. In another study by Carrie Bow in Scandinavia found that women were 3 times more likely, and that exercising women did seem to have a similar or stronger pelvic floor muscles. And that in fact there might be an exercise by having these strong muscles may have a protective effect, but strenuous exercise could worsen the symptoms. So treatment, this works. You do not need surgery. You can do pelvic floor muscle training, and there are specific physiotherapists that are well trained to teach these exercises, and there's no side effects. It is the best and first line treatment for this problem. There are also some prevention devices that can be inserted. However, the pelvic floor muscle training is really the best treatment for this problem. Now move on to harassment and abuse in sport. And I start off with showing this, this picture of the Japanese report that was reported in July 2020, would have been in conjunction with the Olympic Games. And this was a report on child abuse in amateur sport in Japan. And I show you this to just remind everyone that these are actual real people. These things do occur, and harassment and abuse is something that we should all play an important part in preventing. Safe sport is defined as an athletic environment that's respectful, equitable, and free from all forms of harassment and abuse. If we look at prevalence, there's a recent study, a European study, that shows prevalence of sexual, physical, and psychological harassment in these study of Belgian and Dutch athletes. And we know that it occurs in all sports at all levels, with a greater risk for elite athletes, children, LGBTQ athletes, as well as para-athletes. And we know that perpetrators tend to be individuals in a position of power. So there's a power differential between the perpetrator and the athlete. The impacts of harassment and abuse are listed here. Now, not all athletes will have all of these impacts, and not all to the same degree. But you can see that an athlete can have many parts of their life affected by harassment and abuse. And we know that this abuse can be long-lasting, well beyond the end of the harassment and abuse. So what can you do as a physician? What can I do as a physician? We can ensure that our sport organizations have codes of conduct that we have in place for everyone to follow. And if we don't have one, we can use the Olympic Movement Medical Code. We should have education programs to empower our athletes to understand their rights and to educate them as to appropriate and inappropriate behaviors. We should, as clinicians, recognize the different athlete presentations of harassment and abuse. And I can tell you right now, athletes don't book an appointment to talk about harassment and abuse. They'll book an appointment to talk about an injury they may have or a mental health problem they may have. And you have to dig and ask for it. Now, you don't have to ask everyone who walks in the door, but if you see a pattern of behaviors or injuries that don't make sense or disruptive behaviors, please ask. And you can open the door just by saying, in other athletes who present like this, they've often been subject to some unhealthy or unhappy behaviors. Are you okay? Is there anything that makes you unhappy in sport right now? Is there anyone trying to harm you or hurt you? And just by asking those questions, you've opened the door, you've given them permission, and they may come to you one day, if not that day, and talk about what's happening to them. Make sure you have an appropriate clinical approach to managing the disclosures and a multidisciplinary team that will help you support the athlete after their disclosure. We'll close off today with our final female athlete health topic of exercise and pregnancy. And you think, well, this isn't so important to me as a physician in sport medicine. This topic is the highest topic that's searched for in the British Journal of Sport Medicine. Now that surprised me. I thought it would be knee injuries or shoulder injuries, but it's actually exercise and pregnancy, safe exercise and pregnancy. And this is a common topic of discussion in non-athletes, but also, as we see in the Olympic Games, the age of our female athletes is increasing and sport careers are getting longer. And often I see in some of my athletes is in between the Olympic cycles, they will have a child in the first year post-Olympic Games, which gives them time during the quad to increase back up to the next Olympic Games. So we are well aware, and there's a nice description by Carrie Bow, the Scandinavian as well, who is the lead author in the IOC's consensus statement on exercise and pregnancy. And here she talks about the different modifications or adaptations both to the fetus and to the mother from exercise. And I won't walk you through that, but you can explore that on your own. There are musculoskeletal adaptations, changes in balance, changes in cardiorespiratory function, metabolic changes, as well as thermoregulation and effects on endurance training. So we cannot take a female athlete who is pregnant and expect her to have the same sport outcomes from training. As well, flexibility changes. There's a slight higher risk of miscarriage during implantation phase with high impact or high strain exercise, very slight. And these studies are not done in elite athletes, and they have quite low levels of evidence. So this systematic review, this is also led by Carrie Bow's group, it's part 2 of the IOC consensus statement, shows that exercise itself during pregnancy reduces excessive birth weight. Now that doesn't mean that they'll be low birth weight, that will decrease the macrosonic baby, the unhealthy large baby. There's no evidence that exercise during pregnancy causes premature labor, changes in the infant's APGAR scores, or the duration of labor. And exercise decreases the chance of operative delivery. So lots of positive benefits from exercise during pregnancy. So should all sport be safe? Well, wouldn't that be lovely, but it's not. There are some sports that should be avoided during pregnancy, and those are ones where there could be trauma to the abdomen, such as ice hockey or where there's a stick or a ball. Any physiological risk to the fetus, such as scuba diving. Any sport where there's a sudden deceleration that might affect placental viability, and I've listed some of them here. And let's focus now on the return of our athletes to sport in the postpartum period. And there's different factors that you must consider when you're deciding when it's safe for this athlete to return back to exercise. And that includes the list here of perinatal complications. What kind of pelvic floor injury occurred or didn't occur? Was it an operative delivery? And are they continuing to breastfeed? Now, the evidence shows that exercise while breastfeeding does not impact either on the composition of the milk or the quantity of breast milk production. So it's safe to breastfeed during exercise. And will exercise change these complications? So this is also part 3 of Carrie Bow's work as the consensus statement in the BJSM. And interestingly, this systematic review showed that weight loss is not impacted by exercise in the postpartum period. Very low level evidence. Depression as well, not affected, but low back pain and pelvic girdle pain was positively affected by exercise. No evidence for decreasing the risk of diastasis of the rectus abdominis muscle, but there was moderate evidence to show that pelvic floor disorders can be prevented by exercise. So the bottom line is exercising postpartum is safe when the woman has recovered from the delivery, but the gains are not as full as maybe we once thought, but still very safe. And there are some significant benefits from exercising in the postpartum period. So I'd like to thank you for your attention today, to listening about how we can keep our female athletes healthy. And particularly, I thank you not just for listening today, but for your action on how you will take what you've learned today and implement it in your practice in caring for our female athletes. Thank you again to the organizers for the kind invitation. I wish I were with you in person. I will say à bientôt, à la prochaine, which is French for saying next time in person.